We are live now, doctor.
Yeah, thank you. So, yeah, a very good evening to everyone who's joined us today and who are going to join us and also look back at this webinar, because I think there'll be a lot of pearls of treatment of thyroid eye disease in this. So, this is the rough outline of what we're going to be talking about. And this is the team Yosi, which is behind this webinar and all the Yo activities that we have, and of course the huge team of the executive committee, some of whom are here with us today as organizers of this webinar as well, and the various offshoots and committees of Yosi, which do a lot of work to spread the good work and to involve fellows and postgraduates. And of course, coming to the YOSI Oculoplastic Focus Group, which is led by Dr. Puneet, has Dr. Nupur, myself and Ayushi and Rolika who are here, Dr. Shruti. And today we have a very nice panel of very apt speakers who will give us a great insight into thyroid eye disease and its various facets. So, first is none other than Dr. Surya, who is the director of operations across the LB Prasad Eye Institute network, and he heads the ophthalmic plastic surgery service at the Bhuvaneshwar campus. And he was also the campus director and head of education there, and he underwent his training at LB Prasad in Hyderabad and joined the faculty in 2006. So he's very apt for us because he's in charge of the uh, International Thyroid Eye Disease Society and was the editor of a textbook also that a lot of us do refer to of surgery in thyroid eye disease. So very glad to have you on board, sir. Next, Dr. Tarjani. She is the associate director of the CAR campus, LV Prasad in Hyderabad, the current acting general secretary and joint secretary of OPI, and she trained in Ganpati Nethralaya Jalna, followed by again her training in ophthalmic plastic surgery at LV Prasad in Hyderabad. And she's an extremely innovative surgeon and has brought across many new things like the orbital tissue expander for congenital anophthalmia, osteointegrated exentration processes, and many more. And she even won an international best paper award for imaging in thyroid eye disease. So a lot to learn from Dr. Tarjini, and we always enjoy her talks. And Dr. Sumita Muthu from Narayan Nethralaya, she completed her education at Bangalore Medical College and her fellowship in pediatric ophthalmology and strabismus in Narayan Nethralaya. She is also one of my teachers, although we don't have too much of an age gap, but she taught me possibly a lot of everything I know of pediatric ophthalmology and neuro ophthalmology. And she is one of the people who, we refer patients to commonly for strabismus in thyroid eye disease. So she would be best to speak about this as well. And my co moderator, Dr. Ayushi. Uh, she's probably one of the most active people in the oculoplasty focus group. And now she's a consultant at Nandadeep Eye Hospital in Sangli. And she's already sharing and putting up a lot of information about the work that she does. So, very grateful for that. And she again has won many awards, um, uh, Best Paper Awards and Best Poster Awards. And she's also one of the editors of the Yo Slides. So glad to have you, Ayushi.
Thank you, Dr. Rituja, for this opportunity and also for this wonderful initiative on thyroid eye disease. Dr. Rituja is a consultant in orbit and oculoplasty at the Vision Eye Center and also visits Safe Sight Center, the Healing Touch, and the Delhi Eye Center. She has completed her oculoplastics fellowship from Narayana Nethralaya in Bangalore and has served as the editorial member at DOS Times and was also part of the team for the oculoplasty issue when we released the famous U Times. So thank you so much for this initiative. We'll kickstart this session with our first very important talk by Dr. Sumer. He has done his ophthalmology residency from DY Patil in Mumbai and is currently pursuing his long-term fellowship in ophthalmic plastic surgery and ocular oncology at LV Prasada Institute, Hyderabad. A very dear friend and colleague. Welcome, Dr. Sumer, and you may now start the session with your important talk on evaluation of thyroid eye disease under the mentorship of Dr. Tarjani.
Thank you so much, Ayushi and Rutuja. I hope you can see my slides.
Yes, we can.
Yes.
And yeah, okay, great. So I was told that this is going to be viewed by a lot of residents and fellows and general ophthalmologists. So I want to keep this very basic. A lot of what we see in thyroid eye disease, or a lot of what we are exposed to in residency in thyroid eye disease, is somewhat looks like this, which is in our textbooks. It's a lot of signs, it's a lot of names, and that kind of tends to put people off the disease. But actually, what we see in the clinic is somewhat like this. It's got a very varied spectrum. It can range from mild to very severe disease, can even threaten vision. So, what I want to do is to take everyone through with a group of cases from what we see in the thyroid clinic, and then the panelists which follow me can guide us further on how we manage them. The objectives would be to elucidate the importance of taking a good history, what we should be asking for in a good comprehensive history, to assess activity and inflammation of the disease, to grade it as mild, moderate, or severe, or at least have a grading in mind when we look at the patient, to look at the visual, not just acuity, but beyond visual acuity, which I'll touch upon in the upcoming slides. And also, very importantly, to manage expectations of the patient depending on when they actually do come to us and what stage of the disease they are at that moment. The way this presentation is structured is I have divided every case into 4 components. The one on the bottom left, as you can see, is the symptoms, then the vision and vision related or signs and symptoms, the activity of the disease, and a conversation with the patient, wherein we counsel the patient depending on what their expectations are. So we'll move into the first case. We have a 31-year-old gentleman who came to us with proptosis and upper lid retraction in the right eye. He had no history of pain and his thyroid function was normal. He's noticed these signs since the last 9 months. He's not a smoker, he's not diabetic, and has no other systemic complaints, and was, as I mentioned, clinically euthyroid. If you look at the picture on the left side of the screen, we can see that there is an obvious upper lid retraction in the right eye, and not much, maybe a very mild proptosis, not too much congestion. And we've also performed a CT scan for this patient, which shows very mild enlargement of the recti in the right eye. And probably it could have some enhancement at the SRLPS complex. If you have to put this patient in a category of mild, moderate, severe, it would be but obvious that this patient lies in the mild category. And his visa scoring, which I'll touch upon again later, puts him in active disease. His CAS score is 1/7, and we would put this into unilateral euthyroid active TED. We decided to continue lubricants. He was not happy with his lid retraction, for which we injected intra steroids into the levator, and he did very well. He maintained after a couple of intralesional steroid injections, and his retraction has settled well. So the opposite side of the mild spectrum can be highlighted by this gentleman who came to us for cosmesis in the left eye. He's had proptosis or bulging of the left eye since the last 2 years. Once again, clinically euthyroid, non-smoker, no diabetes, and he showed us previous photos which had very similar amount of proptosis for the last 1 year, and the disease has been stable. Of course, we can see the proptosis in the lid retraction. The imaging shows us it's a fat predominant disease. And since this patient was cosmetically concerned, we could offer him a two wall with fat decompression, and he did well. So just to summarize mild disease, what's important is when they come to us in the active stage, we need to note down risk factors, looking at smoking, looking at the control of the thyroid. Are they diabetic? What is their age? Do they have any comorbidities? Because all these risk factors will probably prompt them into going into a more severe form of disease and might affect how we monitor or treat these patients. We also need to look for subtle signs like diplopia, eyelid retraction, and those subtle signs which could be missed probably if we don't look at them carefully in the clinic. Let's move on to a bit more advanced or moderate disease. This 65-year-old gentleman came to us with proptosis or bulging of the left eye since the last 2 years, which was now stable. When he had proptosis 2 years back, he was given IVMP as per UGOGO protocol twice elsewhere, and that settled the disease at that time. But since the last 4 months, he now has proptosis in the right eye. So he has sequential involvement of both the eyes. He's a non-smoker, but he is diabetic. And his main concern was he had diplopia. We can see an asymmetric proptosis, and he also had high IOP of 25 millimeters of mercury in the right eye. We can just look at this coronal cut of the CT scan, which shows us an enlarged muscle belly of the medial rectus as well as the other muscles, but prominently the medial rectus in the right eye. This patient had already had UGOGO protocol twice for the left eye. We decided to start him on steroids. We could also think of orbital steroids. And since this patient was refractory to steroids, we also gave him the option of tocilizumab immunomodulators, which he went ahead with, and the disease eventually stabilized. Once again, something on the opposite side of the moderate spectrum is this 35-year-old lady. When she came to us, I'll just go back to the previous slide. When she came to us on the previous visit, you can see that there is some lid retraction and there is an active disease. We waited for this disease to settle down. So you can look at how the disease has progressed in 1 year. And now she's had this bilateral proptosis or bulging since the last 3 years. She's a non-smoker, not diabetic, and she is hyperthyroid with currently her thyroid levels were not stable. She had asymmetric proptosis and subtle ptosis in the right eye, which could be aponeurotic variant of ptosis, but we should also look at other causes of ptosis such as myasthenia in these cases, because autoimmune thyroiditis, although more common in hypothyroidism, is associated with myasthenia gravis. The CT orbits showed a mixed pattern of disease with rheumy sinuses, a thick trigone, and a high skull base, which I've not put up, but all these were to assess her orbit when we could kind of plan out a decompression for her, and she did well after decompression. Summarizing, moderate to severe disease may be active or inactive. What's very important is if they do come to us in the active stage and it is really moderate disease, these would be the borderline cases where we would consider putting them on UGOGO protocol and putting them on IVMP, assessing their proptosis and very importantly, the diplopia, and also monitoring their vision, their color vision and other parameters like I'll talk about in the next slides will be important. In these cases, rehabilitation becomes very important because there can be a lot of psychological burden on the patient, especially when the active stage is over and now they're frustrated after 2 to 3 years of active disease and they're left with residual proptosis, which we now can treat with surgical decompression. So this is an interesting case of a 52-year-old gentleman. As we can see, he has a very apparent bilateral proptosis, but more importantly, exposure-related changes in the right eye with substantial chemosis and corneal breakdown, as well as a sterile infiltrate over the cornea. We can see there is so much lag of ophthalmos, he is unable to close his right eye. He had these symptoms which rapidly progressed in the last 3 months. So that's obviously a very, very severe disease. He was not a smoker, but he was diabetic with sugars all over the place, and he also had kidney disease because of his sugars. He was hyperthyroid with on treatment, and he had also had IVMP 6 doses elsewhere. And he came to us after these 6 doses because he wasn't responding very well. You can see very grossly enlarged muscles on the CT scan. There is bilateral proptosis, exposure-related changes, and his right eye color vision, which is an important parameter, was low. Visa-wise, it is obviously an active disease, CAS 4 to 5, and because his color vision is low and there is a bit of effacement of the muscles of the optic nerve, we thought of dysthyroid optic neuropathy with corneal breakdown as well. In this patient, we subjected him to obviously our options because of the vision threat was steroids, immunomodulators, and decompression, and with a lot of further management in the form of radiation, steroids, and eventually decompression, he did very well. So this gentleman had been referred from one of our secondary centers with a complaint of proptosis since the last of bulging of the left eye since the last 6 months. He was hypothyroid and had been given IVMP locally, not a smoker but diabetic. And what the concerning point was that his visual fields, as you can see in the central panel, are grossly diminished with a scotoma, and there is also maybe 25 to 50% of the nerve which is touching the muscles. And this becomes a concern because we again are suspecting sight-threatening disease in him. Because of the compression of the nerve and suspecting this thyroid optic neuropathy, we have the options of IVMP to instantly give him pulse dose of IVMP. He had a suboptimal response to this IVMP, and he had to undergo urgent decompression in order to save his vision. What I want to highlight, which is of utmost importance, is that when it comes to sight-threatening disease in thyroid, you can have a patient with 20 by 20 vision and even subtle proptosis who can end up having sight-threatening disease if you don't look at all these parameters. Diminished color vision probably, and also with the right chart, with an HRR chart, looking for disc edema, for RAPD, even for red desaturation, which is a very easy test that every resident or fellow can do in the emergency department. All these tests combined together can guide us along with imaging to pick up these subtle signs and treat these patients promptly. So what I would like everyone to take back to the clinics is the importance of history taking, looking at thyroid levels. Are they smokers? Are they diabetic? And counsel them appropriately. The importance of clinical evaluation to stage a disease as mild, moderate, and severe, and to put it as active and inactive. And beyond that, to look at the vision, the IOP, the color vision, to have a thorough intraocular evaluation even of the fundus, and most importantly, managing the patient's expectations. What is the actual concern of the patient, and at what point of the disease has he presented to you? And according to that, we can tailor how we want to manage this patient and what we can offer them. So these are a few references that would be important, and a kind of landmark papers that would help residents and fellows. Thank you. And we can open up for questions.
Thank you so much, Sumit. That was a lucid presentation, and you covered so many cases within such a short span of time. I have one question for Dr. Tarjini. Sometimes we do have cases of dysthyroid optic neuropathy who have received IVMP multiple doses from multiple places. So, do you do give a trial of IVMP again, or having known that they have not responded before, do you go for a surgery first?
Well, if they've received enough steroid in good dose and they haven't shown response to it, then I would jump into surgery. Surgery somehow miraculously sort of, treats not only the compression of the optic nerve, but the inflammation also responds very quickly. And in any case, with the surgery, you invariably tend to start the patient on steroids as well in the peri-surgical period, especially IVMP. So that's what I would do.
Right.
But
And
then
I'm just
it's a very evolving landscape, and we'll discuss that in the medical treatment. So there are several options.
Right.
just to add to the question that Ayushi asked, like the case that Sumer presented with the diabetes component, what was your reservation? Because IVMP was already given for 6 cycles, along with the fact that he was a diabetic and has DON. So, what was your reservation in that case?
Why did we not treat him with surgery? We did treat him with surgery. So that was a patient
Yeah.
who perform orbital decompression for. Surya actually has published about diabetes as one of the risk factors, modifiable to some extent, risk factor in thyroid eye disease. And we know that these patients sort of tend to fare poorly. So in such a situation, I would certainly go ahead with decompression.
Right. Ma'am, reservation I meant was that when he came, that IVMP was already given. So the first step that you had in mind was decompression. And would you even consider immunomodulators like rituximab, maybe?
Yeah, so it's a very, very evolving landscape at this point of time. Based on your clinical radiological assessment, the risk factors, and predicting what the disease course is likely to be based on these factors and the natural history of the disease, you can individualize a treatment plan. There are patients where even if you want to perform a decompression, you may not be able to perform a decompression, those with bad kidney diseases, and you'll have to resort to alternate methods, like even injecting orbital steroids in the presence of dysthyroid optic neuropathy. But what would I do in a naive case? I would give steroid. If the steroid is given in sufficient dose and has not responded, I would go to decompression. If I can buy time, the patient is not fit for decompression, that is where I would sandwich all the other treatment options like immunomodulators at this point of time, given what is available in India.
And one more question, ma'am, that
Dr.
for the transconjunctival triamcinolone that you give, any suggestions or points to be kept in mind while giving the injection and about the plane to choose?
So, that was one of the very old photos which I sent to Sumer. But what I actually do is inject in the belly of,
Now, yeah.
the muscle.
Oh,
So I directly give it like a frontal nerve block and inject closer to the belly of the levator muscle. So
okay.
I would use a half-inch needle, 26 gauge typically, and about inject 1 ml of Kenacort, 40 milligram per ml to observe these patients. Obviously, sometimes they require 2 or 3 injections. But when you have clinical signs of active inflammation, clinical radiological signs of active inflammation in the levator, and you inject steroid, you will see a response. If you don't have signs of inflammation, your steroid will not do anything for the lid retraction.
Thank you, Dr. Tarjini. And after Sumer's wonderful talk, and now that we have the whole spectrum in mind, the various types of issues that can be present, different types of management, we'll go further deep into the management, medical management, that is, with Dr. Tarjini's talk. Over to you.
Thanks, Rituja. Thanks, Ayushi and Rolika and the entire team Yosi for having me. Sumer has actually made things very easy for me. Nonetheless, I'll speak to you on the lines of how exactly we evaluate thyroid eye disease patients for the treatment, how we individualize the treatment, what are the options we have in the medical management algorithm at this point of time, and a little bit on cases that we tend to see in India more frequently than what the West sees, and how that changes the way we manage patients to an extent. Again, this is what I was alluding to earlier. It's just a perspective based on scientific evidence. There's no right, wrong, good or bad here, but it's a perspective based on evidence that I'll be presenting to you today. When you look at the treatment phases for thyroid eye disease, you have the disease in the active or what is supposed to be progressive phase where there'll be some sign or symptom that's progressively changing, and you have disease which is in the stable phase. When you are looking at medical management, you're largely looking at targeting the active phase of the disease. And it'd be important for people to understand how do you individualize that treatment in the active phase. The points that you should evaluate your patient on, other than the risk factors for individualizing your treatment, would be to look at the activity and severity of the disease, and to some extent focus on what are the risk factors. There are several modifiable risk factors at this point of time. One of the biggest ones is exposure to nicotine. Smoking forms a very big modifiable risk factor, active as well as passive smoking. And that's a conversation you should have with every patient to keep away from nicotine. Diabetes, obstructive sleep apnea, thyroid dysfunction, and prior radioactive iodine treatment are certain other modifiable risk factors. There are some emerging risk factors which haven't been evaluated in a randomized control study, but there is enough evidence to put them up here, and these include dyslipidemia, microbiome alterations, and low levels of vitamin D in the patient. Now, here's a concept that everyone needs to understand in terms of managing thyroid eye disease, and that's your activity and severity of the disease. Before we jump into that, just wanted to give you an example of how an active disease is ideally supposed to progress. This is what we've been taught in textbooks, that you'll end up seeing patients with proptosis and lid signs. And as you follow them up, if they come to you early on, you might see them with inflammation worsening. And you have to pick up those subtle signs like eyelid edema, which is here, which wasn't there earlier, more congestion, caruncular congestion, pain on eye movements, and all of these signs to sort of say that, yes, the patient has certainly progressed from the top panel to the bottom panel in a period of 3 months. And that, along with the risk factors for the patient, helps you individualize treatment plan. Here's a curve that all of us should remember. This was proposed by Rundle, and this tells you the disease time course and what your intervention strategy should be. So when we say active, what do we say? Active phase typically lasts from the onset of eye disease for about 1.5 years in non-smokers and about 3 years in smokers. And it's in this phase that you can see either mild or moderate or severe disease presentations like Sumer was showing. And that's where the disease is climbing uphill. What is your aim? Your aim is to figure out and make a prediction whether this patient is going to end up with severe disease or not. And if you think that is going to happen, halt the disease early on in the active phase so that the final fibrotic sequel of the disease is minimal and the patient tends to come back to normal. If you do not initiate treatment here in the active phase, you're going to end up having a patient who has significant comorbidity, even vision affected for that matter, and then treating that is going to take a lot of effort compared to starting immunomodulation early. And these 4 graphs, let's just take one at a time. A is what I just showed you, the dynamic phase, and then the static phase if you don't do anything. If you start immunosuppressive early on, as you see in B, you see that the outcome is that the disease fades away, burns out, and the patient comes back to near normal appearance and function as it was before the onset of thyroid eye disease. But if you've started immunosuppression late, you will make no difference in the outcome of that patient. And that's where you're going to need rehabilitative surgery to bring them back to normal. And this is very important in understanding and plotting every single patient. So you'll have to do this for every patient in your clinic. One another thing that when you start seeing numbers, right, you will see patients over decades and you'll realize that there are a significant proportion, at least 10% of patients who come back with reactivation of thyroid eye disease. So you have this gentleman here who I've seen in 2014. And then he came back in 2024 and I performed an orbital decompression. And this is, he had already had a prior orbital decompression actually. When I saw him in 2014, you can see that his lateral wall anterior part was decompressed on both the sides. We performed additional decompression in 2024 and see what happens after additional decompression. From the adipogenic variant, his muscles enlarge. You see that gross enlargement of extraocular muscles. This is not only muscle swelling because you've decompressed the orbit. This was actual active disease. He had thyroid dysregulation. He had corneal breakdown. We had to put him through a tarsorrhaphy, and we are managing his second active phase right now with immunomodulatory therapy. So this is something that you should remember as far as thyroid eye disease is concerned. So we've discussed activity, and then severity is like Sumer pointed out with the mild, moderate, and severe cases that you might get. And you need to understand both activity and severity to plot a treatment plan for these patients. So what do we have as far as treatment is concerned? We've had in India glucocorticoids, mycophenolate, to some extent rituximab and tocilizumab available as immunomodulatory therapy. And you can see all those circled in red that are currently available around the world, and all those circled in purple that are in clinical trial phases. What are these immunomodulatory agents doing? They are essentially reducing the downstream inflammatory markers that come up due to thyroid dysregulation. So essentially, with thyroid eye disease, you have increase in glycosaminoglycan deposition in the orbit, which sort of produces proptosis. All this also goes and deposits in extraocular muscles and therefore gives rise to the rest of the symptomatology that you see. And what immunomodulatory agents, including steroid, try to do is to suppress this inflammation at different stages. This is just because this is a talk for residents. I just tried to put up all the drugs currently. This can actually be a quick snapshot for you that are in different clinical trial phases at this point of time in the treatment of thyroid eye disease around the world. But if you come back to our situation, what essentially do we do in clinics? We divide into mild, moderate, and severe disease. When it is mild disease, we largely give them supportive treatment like lubricants, head elevation, selenium deficiency should be corrected if there is any. And we also treat eyelid retraction by temporary means such as steroids or botulinum toxin or an orbital filler injection. For more severe disease, which falls in the spectrum of moderate to severe, corticosteroids at this point of time remain your mainstay, and immunomodulators are making their way into the management as first-line treatment options at this point of time. There's also orbital radiation that we'll look at shortly. When it is sight-threatening disease, you're going ahead with high-dose IVMP, followed by urgent orbital decompression, radiotherapy, and immunomodulators again are treatment options for sight-threatening disease. And here's the protocol that we tend to use. For those in the active phase of the disease, we typically tend to give 500 milligram weekly for 6 weeks, and then 250 milligram weekly for the next 6 weeks. If it is suboptimal, then you can repeat the Yugogo pulse. If you feel the disease is not halting, the inflammation is not halting, that is what you can do. If you feel the patient is not responding to steroid, then that's the time to think about a change in the immunomodulatory strategy. And instead of steroids, you want to introduce either rituximab or tocilizumab, which are the two drugs which are available in India, or consider radiotherapy. When you have optic neuropathy from thyroid eye disease, it's a higher dose. You're giving 1 gram daily for 3 days. Eventual cumulative dose is the same, which is 3 grams of IVMP that you have given. If this is not sufficient, you can actually repeat these 3 grams after a period of 1 week. And if that also does not correct your optic neuropathy and patient's vision and color vision remain suboptimal, you can add orbital decompression or radiotherapy to these patients. What has the European group for thyroid eye disease or Graves' orbitopathy recommended? They've recommended pulse IVMP with mycophenolate mofetil, which means two drugs, as the first line of treatment for thyroid eye disease. And this is something that happens when you initiate these drugs. You can see that the inflammation goes down, the lid edema has gone down, but the proptosis and motility restriction typically does not change with the first line that we have available with us right now in India. Just a little word on mycophenolate. It's a precursor to mycophenolic acid, which essentially kills the activated T lymphocytes, which are the criminal cells in thyroid eye disease. And what mycophenolate helps us with is it improves the rate of response to therapy. When you start mycophenolate along with glucocorticoids, you have more efficacy in managing the thyroid eye disease rather than glucocorticoids alone. But long-term adverse effects of mycophenolate at this point of time are not published. So what are the other drugs? I said that it's a rapidly evolving landscape, isn't it? So these are the other drugs that are available. Teprotumumab has actually made its way in most parts of the US and in Europe, and to some extent in Australia as well, and Hong Kong. But it's not available at this point of time in India. It's a drug that controls a different pathway via the insulin-like growth factor receptor. So this drug essentially has been the only drug which helps in reducing proptosis. But long-term outcomes of teprotumumab are coming out now, which are very suggestive of recurrent disease, reactivation of disease once treatment has been stopped. And it has two major side effects. One is new onset of diabetes mellitus, and second is hearing loss. And these are two very significant side effects that a drug can give a patient with thyroid eye disease. And therefore, it's currently sitting on the fence. We don't know which way it's going to go. Here is a patient who, if you plot him on the activity, he's moderate in severity, but if you plot him on the activity score, he has absolutely no inflammation. His problem was diplopia. You can see that he has some amount of motility restriction. He also can't see up very effectively and had significant diplopia in primary gaze. And all we've done for him is treat him with tocilizumab. He was diabetic, uncontrolled, could not be given steroids at that point of time, treated with tocilizumab. And you can see that his motility has actually improved at the end of 8 infusions of tocilizumab, which are taken at every 15 days interval. We follow the subcutaneous injections for tocilizumab. These are given at an infusion center, always in sync with an immunologist. So this is one another drug that is widely used in Canada, to some extent has been used in Asia as well. And outcomes following tocilizumab are currently just coming out in terms of few papers where it's very difficult to come to a conclusion. But one of the things that it possibly might help with is diplopia. And if that happens, it's a great drug to have, because that's one of the most, rather the worst fibrotic sequel of the disease to have. On similar lines is radiotherapy. Where does radiotherapy help? It certainly does not reduce proptosis or eyelid retraction. What it helps with is dysthyroid optic neuropathy. If started early in the active phase for a patient with dysthyroid optic neuropathy, it has shown to be able to avoid orbital decompression in up to 94% of cases. So this is one of the biggest sort of, pluses of orbital radiotherapy at this point of time. It certainly comes with its side effect profile. You cannot use it in diabetics. Radiation retinopathy, cataract, dry eye is all side effects of radiotherapy. Radiotherapy in thyroid eye disease is generally low dose radiotherapy. Nonetheless, you're likely to see these side effects following orbital radiation. So that brings me now to two other situations, one of which is sight-threatening disease. And in sight-threatening disease, you can have dysthyroid optic neuropathy, or you can have corneal involvement. Here's a patient with dysthyroid optic neuropathy treated with 3 grams. We followed up, and in 1 week, again, the vision significantly dropped. The color vision also dropped. And this is a patient who we promptly took up for orbital decompression. And you can see this is about a month post decompression, where the compression on the optic nerve obviously resolved, but also the inflammation very rapidly sort of settled down. And here's just her radiography pre and post decompression, where you can see the muscles have now prolapsed. Typically, in these situations, you'd want to go ahead with a medial wall and floor unbalanced decompression, because medial rectus and inferior rectus are the culprits in thyroid eye disease, which tend to affect the optic nerve the most. And when you have corneal involvement, then here you have to judiciously start IVMP. You also want to put in all measures to sort of reduce the proptosis, because that is, and the chemosis, because that is what is contributing to the sterile corneal infiltrates. So you can go ahead and decompress the orbit, give steroids, give appropriate topical antibiotics with the help of a cornea specialist, and manage the corneal disease. Here's her pre and post radiography showing you the decompression that has been performed. Now, what do you do when you have disease which is active in your timeline, but clinically you don't see any activity or any signs of inflammation? Let me put it that way. These are all patients which are in their first 9 months to 10 months of thyroid eye disease. So if you have to plot them on the Rundle's curve, they are here. It's very difficult to make a prediction which patient is going to progress and which patient is not going to progress. So what do you do in a situation like this, where clinically everything looks silent, but they are in their active timeline? They are in their first 3 years of onset of eye disease. Here's where you treat the symptomatology. Most of the times they tend to have grittiness from dry eyes, and they have a very poor ocular surface disease index, and lubricants do help. Head elevation helps at bedtime, because inflammation is typically worse in the morning in these patients. Smoking and all other modifiable risk factors should be addressed. You can use prisms if they have diplopia in this phase, which is very common. Again, the eye looks absolutely white, but they may have diplopia. And for the eyelid retraction, you can either go ahead and treat them with steroid like Sumer showed, which you can see here in the bottom panel, or with botulinum toxin, as has been used in this lady in the left upper eyelid. These are options that you have till you await the disease going into burnt out stage, where your eyelid retraction and proptosis can be treated with surgery, which is decompression and then a recession of the upper eyelid. Now, what happens in the Indian scenario? What we have been taught or what we saw until now is, when you see serious inflammation of TED, you certainly have to treat with all forms of immunomodulators that we just discussed. But when you have this non-inflammatory TED, you don't know which way the patient is going to progress. When you have this silent disease, that's where you have to make certain predictions. And what we treat them with currently is lifestyle modification and a little bit of upper eyelid recession with either Botox or steroid or lubricants or whatever we are using. So that's the thought process that we've been given. Here is where I want you to focus on the progression of the disease. It's always a good idea to look at these patients. For example, this gentleman in Jan 2020, and then in October 2022, and no difference, right? So this is a stationary thyroid eye disease. It's always been non-inflammatory, never threw up that classic inflammation of thyroid eye disease. His active phase is now over, and if he desires any treatment, this is a time point where you can actually go ahead and treat this patient. But look at this lady, right? This is just a matter of 3 to 4 months, and you can see that she has progressed. So when you have your non-inflammatory disease, follow up these patients for progression. If you see progression come up, you are justified in starting some form of immunomodulation for these patients. And I'll show you this with the help of this gentleman, right? 2018 all the way to 2019, worsening right eye proptosis, left eye absolutely normal, correct? And then look at what happens over the next couple of years. 2020, now left eye has started getting involved. So this is another thing in thyroid eye disease, that both eyes may have an asymmetric onset of disease. And it's always a good idea to follow these up and not jump into surgery in the initial phase, and consider surgery only once you're sure that there has been no change for a period of 6 months, which is when you'll say that the disease is burnt out. And concluding on this particular topic, when you have a score, inflammatory score, which is on the lower side, it's very easy. You treat them conservatively. When you have an inflammatory score on the higher side, again, easy, do immunomodulation. It's this middle zone where you are confused on whether immunomodulatory treatment will help or not. And that's where you follow up these patients closely, watch for progression. If you do see progression, then consider immunomodulation. And the type of immunomodulation is currently a very, very rapidly changing topic. So in future, what will we benefit from? We will benefit from studying the downstream inflammatory marker in our patients, in Indians. What are those inflammatory markers that they are secreting? And can we target treatment for those inflammatory markers? We can look at that in the tears or in the blood. Certainly having TED models, animal models in TED are very difficult, but having some form of a model, either a cell model or an animal model, will be helpful in testing newer pharmacotherapeutics that may come up. Gut microbiome may have a role, and eventually treatment is also progressing in the direction of precision medicine with genetic modulation. In summary, what we have right now for thyroid eye disease in our part of the world is to look at the disease process and look at whether they are in the active or the inactive phase, look at the severity of the disease, and based on that, treat them. Once the disease has gone into its burnt out or inactive phase, treat the sequel of the disease with surgery. Thank you so much. That's all I had on.
Thank you so much, ma'am, for sharing all the interesting cases. You showed an entire spectrum and it has covered all our doubts and all the usual cases that we see. Am I audible?
Yes.
Okay, perfect. So, ma'am, I have a question for you, and that would be like in the case that you showed where there was a second activation. I think it was in the first few cases, very interesting case with the thick muscles and probably an optic neuropathy as well. You mentioned that you started immunotherapy. So, what was your rationale behind it, and which immunotherapy drug did you choose to use?
So he's a gentleman who's donated his kidney to his sister. So he has one kidney. So that was one of the major factors. He's also diabetic. So that was a second factor. We've given him steroid several times he has a very long follow-up. He's had several inflammatory episodes and corneal breakdown episodes. He's had 3 orbital decompressions till now. And the final panel that I showed you was with him on treatment with tocilizumab.
Very nicely handled cases, ma'am. Over to you, Ayushi.
Yeah. Thank you, Dr. Tarjini. A wonderful talk as always. We'll move on to Dr. Surya's talk. And so we roughly, since it's a focused thyroid talk, we know about orbital decompression, but Dr. Surya will take us further into endoscopic orbital decompression, which is not often that we get time to discuss it. So over to you, Dr. Surya.
Thanks. Thanks. This is really nice to actually have this discussion on thyroid eye disease today, and a wonderful talk, Tarjani. I mean, it's much easier with the entire spectrum talked about. So I could probably just jump in. Beautiful slides, by the way, Tarjani. So actually, first of all, when this sort of discussion had come on the topic, I guess I remember that this was more on a generic surgical management, but keeping the time constant in mind, I had chosen endoscopic, but I'll stick to that. I would like to probably just focus on the thing that what is the kind of disease where you would actually use this particular technique, and how exactly does it benefit the patient? How do you choose? What are the things that you should be thinking about? We've already talked about the different, the mild, the moderate, severe, and sight-threatening disease earlier. And obviously, for reasons you would actually be focusing on using decompression predominantly in the moderate to severe or a sight-threatening disease. Now, we've also looked at the Rundle's curve, and typically, actually, when we were treating from a traditional, I would say a typical you-go-go protocol, this is how it actually fanned out. You had a patient and then he progressed, you used intravenous methylprednisolone, he finally settled down, and then you used your multiple surgical modalities to bring him to where you want him to be. Let's say to near normal, if you can say that. Modalities less available today have changed that spectrum, and the blue line at the bottom tends to tell you where we tend to probably take them with modalities like subconjunctival tocilizumab. But the interesting thing is the need for decompression is it's over, or is it very few that end up needing decompression? I wouldn't say that, because a fairly large number of patients, even today, with the modalities that we use, tend to use decompression as for rehabilitation or for the active disease. The first one, jump in, is what Tarjini talked about: sight-threatening disease and dysthyroid optic neuropathy. We've seen what are the typical signs and symptoms. Just would like to highlight that we talked about, Sumer beautifully showed that, there are some investigations, very simple one. The color desaturation is a very simple one, and actually turns out is very highly sensitive in my view. I would also like to highlight that the color vision we talk about is a very sensitive one, but which one do you actually use? Now, we all know that in acquired color deficiencies or acquired color problems, most of the times you have to look out for a plate, and the typical Ishihara chart doesn't work out very well. So these are things that kept in mind. Now, this particular individual presented to us with dysthyroid optic neuropathy, and I've shown the CT pictures also, just to kind of show the kind of involvement of the muscles that is there. And if you focus on the right picture of the coronal scan, just how crowded the orbit is. And I would put it this way, that in today's case scenario, after looking at the risk factors, if I am looking at an individual with TD, which more than 2 or more risk factors, and I would keep the ones as major risk factors as number 1 is old age, number 2, male, number 3 is diabetes, number 4 is smoker. Radioiodine is not so much of common in our scenario, but yes, if it is there, then that's another one. These are the ones which, if they are there, then you are seriously thinking about doing surgery first. And that's how I would do it these days. And let me show you what exactly. Now, this particular individual had, on the very first day of surgery, his color vision had started showing some change. And he underwent an endoscopic decompression. And his 2 out of 3 and 3 out of 3 at 23 are the right and the left color vision changes. And within a week, he was to 20/25. That's the kind of dramatic change that you see when you're doing decompression. But the point is, if you're in active disease, you're using surgery as your primary modality, you need to understand that you have to take care of inflammation. You're basically buying time, restoring vision, but you have to still look at the disease per se, and the disease is not changing with the help of surgery. So keeping that in mind, you have to still put him on some sort of a protocol which takes care of the disease, and that may be either intravenous methylprednisolone, if you like that, or the risk factors allow you to do that, or something alternative. More often, azathioprine or mycophenolate is less often used in our scenarios now, but some of that. The second patient I have is, again, somebody who'd had this decreased vision, and on the right panel, you can see just how bad she was, barely counting fingers. And MRI on the right bottom panel tends to show, again, the significant crowding. High signal intensity tends to tell you that she is active. And these are fundus images to tell you that the disc edema was also there. Now, this one, I was a little worried, was it actually going to, and she had 5 months of history where the vision had gone down. And that's her after surgery. Now, I've also put the scans there. Again, endoscopic decompression, bilateral. And she actually went on to improve very well in the right eye first, and took a little longer in the left, but did she improve? She actually improved in the left too. The downside, obvious, I ended up with a double vision, which needs correction. So I'm going to delve on that one later. But on the visual recovery, on the challenges that I had, on the fact that this was patient, I had my big worries if I put her onto any other alternative management, and the risk factors I was looking at, I definitely. And then I put her onto a long-term mycophenolate, which she's on, and she's been almost a year after we did the surgery, and she's doing very well. A short video on, can you see this?
Yes, sir.
Can you see the video?
Yes.
Okay. So actually this one, the endoscopic decompression, most of the time I would try to actually take the turbinate. I would still keep the stump. And when I tend to always say that, that kind of helps me keep a sort of landmark for our orientation, an uncinectomy, and again, a swinging door kind of an uncinectomy, quite a bit of usage of a soft tissue debrider. But the point is, you need to take care of the uncinate to essentially to osteomeatal complex. Once you remove that, that gives you access. And two things are important here. What you now see with that yellow star is actually an enlargement of the maxillary antrum. That's very important because at the end of the surgery, you will see that it actually prolapses all the way. And if you have not done that, then you end up obstructing the maxillary ostium, and you don't want that. You're seeing the skull base there. And in this particular video, we already started taking out the lamina. Now, I would feel in an endoscopic approach, the differentiation of the medial to the floor, the strut is very clearly seen. So you tend to preserve the strut more easily. I would also touch upon the end of the video. There are situations where I would actually remove the strut for an enhanced effect. But those are the cases which already have a double vision. I'm not worried about that aspect. And I know that this patient would end up having a double vision surgery anytime later. I was trying to show the sphenoid sinus there, and that's where bone, you can actually take care of the strut, like I mentioned, if you want to enhance the effect, or the patient that I'm dealing with already has not only dysthyroid optic neuropathy, a significant, around 24, 25 millimeters of proptosis. And I want to sort of do multiple things in the same sitting. So I don't need at least surgery later on. And after removal of the strut, I'm actually removing part of the floor there so that I have a much more enhanced effect on the decompression. Next comes to what are the things that I want to really do to make sure that have the desired effect. And like I said earlier, in endoscopic decompression, for that matter, when you're doing decompression for dysthyroid optic neuropathy, you want a pear-shaped orbit. You want to expand the posterior orbit. That's very important to remember. And how do you open up the periorbita? Now, these days, the difference is I would try to open up the periorbita in such a way that you actually have a strip of periorbita protecting the medial rectus muscle. And it does help because that tends to help me in reducing the number of people who end up with double vision. So that stabilization effect is very, very helpful. The number two thing that is important is I would probably, and actually this video shows it from anterior to posterior. I would tend to do it from posterior to anterior. The second thing is you can also actually use drugs to possibly decrease the number of your patients who end up with a double vision, because all of these patients are active. And the simple thing that is important is essentially you are operating upon a hot orbit. So the chances of double, and most of the reports in scientific literature tends to say, is the activity of the disease. And if that is the case, whatever approach you may use, the significant chances. And I'm actually trying to show the medial rectus muscle there. And that's the medial rectus muscle. So you have a good strip of a periorbita, which is protecting. And that's what is equally important. Okay. So now this is an individual where we've done, again, very similar to what I've shown earlier. Look at the kind of, degree of inflammation that is there, the eyelid, the conjunctival vessels which are injected, and all of them, and also the MRI pictures. And this particular individual went for a sequential endoscopic decompression right and left, and he's bang straight. After the surgery, he was put on multiple comorbidities. He was put on an immune modulation after that, and we've got about a 6-7 month follow-up on this particular patient. This is somebody who we had treated during COVID times and had already come to us. So essentially, quite a few patients have come where they have been treated, and like the question that was discussed, who've been treated with intravenous methylprednisolone. I think if I remember well, he had a good about 6 grams of IVMP, which was already given, cumulative dosages, rituximab already given. But I think I would like you to focus on the right scan. So essentially, what it actually gives you is that it tends to, this is the change that you see. This is the preoperative scan, and that's the postoperative scan. So what it actually gives you is that the posterior orbit, and look at how the medial rectus muscle just goes away from the nerve, giving it that breathing space. And that's what the change shows up in the visual function that we talk about. But that's not enough. You've got to take care of the disease too. And that's why most of the time you would actually put them on some sort of a immune modulation therapy later on. Another patient, multiple attacks of dysthyroid optic neuropathy, like the paper that Tarjini was mentioning. It was when patients are diabetic, it's just a binary function, by the way. It's just yes or no for diabetes, not the linear function like the hemoglobin A1C or glycosylated hemoglobins to look at how bad they were controlled. But just the fact that they were yes diabetic ended up having multiple attacks of dysthyroid optic neuropathy within the very first year, which was almost double compared to those who were not diabetic, and also recurrent attacks of dysthyroid optic neuropathy. Now, this lady actually had multiple attacks, but she was treated with intravenous methylprednisolone azathioprine, and then stabilized, and then finally we did decompression at a much later stage. So here we use decompression primarily as a sort of a management modality, as when the disease had already quiescent down with other modalities. This particular individual actually presented with counting fingers vision, and he had DON, active disease again. We did an endoscopic decompression in the right side. The left eye was much better, and then put him onto mycophenolate. The interesting thing is he actually pretty much was improved to only 2200 because already there was damage in the nerve. But he stabilized very well. And I remember, I think essentially this particular patient had a stretch optic neuropathy. And we need to keep in mind that we are dealing with a stretch optic neuropathy. You actually have no other option but to actually do decompression. One of the early ons which actually gave this hint, this particular patient was much earlier on, but that when you have DON, multiple risk factors, this particular anecdotal experience showed us that there's no point waiting for medical management and then doing surgery. Reversing that paradigm tends to do better results. You can always use decompression as also endoscopic decompression as your management as part of multiple other things. This particular lady, we did a combination of lateral and endoscopic. So if you're the ones who believes in the balanced decompression, then like I mentioned, endoscopic plus lateral tends to give you that advantage, and that's something that you can always do. And I would particularly feel the only important thing there is that the strut is more clearly defined and it's much easier to preserve in cases where you do it this way. Corneal breakdown, I think there was some discussion, quite a bit of experience here, and we had I don't know, maybe it's because of the corneal infections that we otherwise also see. And but the key thing that I would like to share here is that we really don't know what are the risk factors which changes the ocular surface problems in TED to the ones who actually end up with actually corneal breakdown. We don't know. And there are several things that are talked about, but nobody really knows which are the ones. And these patients are definitely helped to a large extent by doing an endoscopic decompression, because you've got a thinned out and possible imminent perforation in cornea, and any manipulation around in sort of not doing it endoscopically, you know what are the challenges and how difficult it is. This again, corneal breakdown is not restricted to active disease. It can actually also happen in inactive disease. And that's something that we know. And again, in case you experience that, decompression comes in really handy in taking care. But the thing that is takeaway here is that decompression helps, but is necessary, but is not sufficient in taking care of corneal breakdown. You have to take care of the eyelids. So if you're doing endoscopic, and it's not that it takes you away from doing all the necessary eyelid surgeries for taking care of the retraction, to take care of the, the intensive medical management, to all the ocular surface, the amniotic membrane, everything else. But it's multimodality, and that tends to give you definitely. I would also tend to talk that, it's not essentially only DON, but in cases like this particular individual who had very high intraocular pressures, you also endoscopic decompression comes to your rescue. And this one is where the pressures were much better controlled. And this is something that we often come across. I don't know whether we want to have this essentially, but this was one individual you need to be careful about. And one of the complications that we can often encounter is actually a CSF leak. We face this, and essentially it's a little more challenging when you're doing it with a medial wall decompression or endoscopic decompression compared to a lateral wall. That's not so much of a concern. But in this particular case, we used a mucous membrane graft with a fibrin glue to actually take care of the leak. And that's the mucous membrane graft which was harvested and placed with a glue. I think that's the last slide I have. Essentially, endoscopic decompression, definitely useful as a modality to keep in your armamentarium. You can deal with sight-threatening disease much better. Lower morbidity is a big advantage. And most of the time, you need to keep in mind that surgery only is buying you time, and you still have to take care of the disease per se with your alternative medical management. That's all I have. Thank you.
Thank you so much, Dr. Surya. It's always a treat to watch you performing endoscopic orbital decompression.
Okay, sorry. There you go. Yeah, you should please tell me.
Yeah, I was mentioning that it's always a treat to watch you perform endoscopic orbital decompression. And I still remember those times. And since you mentioned it to be included as in the armamentarium, I wanted to ask you the learning curve for a person who is doing endoscopic DCR versus the learning curve for doing this surgery for somebody who is not trained to do endoscopic DCRs. What do you have to say about that?
Okay, that's a good question, Ayushi. I would put it this way that, if you're comfortable doing endoscopic DCR, I mean, you've almost done halfway. You're almost halfway there. That because you have a reasonable degree of comfort in the region. And if nothing else, you know what structures to protect. But otherwise, I think just like learning any other surgical technique, it is important to probably first of all, counsel the patient. Don't be over promising that, if you're otherwise an orbital surgeon, you can always take care of decompression. You can add doing, and I've done that for quite some time, actually. I used to do the endoscopic approach, then open up, and then through a transcaruncular, I would actually see how well have I done. I've done that for several years, to be honest. And that's there, number one. Number two is, it's a good idea to probably do your first few cases with somebody who can tell you what are the key landmarks. What are the things that you end up, keeping as important, preserved. And we all know when you're doing a new surgical technique, don't try heroics into doing multiple. Select your cases well, and then try to focus on one particular technique which you hone over a period of time. And then you try to play around with a few things. The reason I highlighted on over all the years, I was always worried about, number one, ending up with a sinusitis because the maxillary ostium was not opened enough. And I actually ended up with one such complication, and that too in a doctor. So obviously, that had to be dealt with. But essentially, otherwise, I think it's a stepwise kind of a thing. And if you are a surgeon who's already doing endoscopic DCR, definitely you are already halfway there.
Thank you so much. That was really useful. Just a last question on, I think you once mentioned that you also give botulinum toxin injections simultaneously after the surgery. So, how have been the rates of diplopia, and what have been your experience on that?
I would say, I think we have been doing this for about a year and a half, maybe a little more. And I feel the combination of, we were always preserving the strut in cases which didn't have double vision to begin with. I would say that, number one. Number two, in patients with, when I talked about the strip of periorbita, which is protecting a direct prolapse of the muscle, And third is botulinum toxin in the muscle, all three. But my is that all in patients, if you don't do these, I don't know how much of each of these is contributing. There is almost a 80% risk that the patient would end up with a esotropia. That high. It's a hot orbit, and you're operating for DON. But by doing this, I think I'm at least preserving 6 or 7 out of 10, not all, from going into an esotropia, which I think is not a bad experience, but has to be, over a period of time, it will really show us. And they don't end up. So I think essentially by giving that a combination, you keep the patient within his BSV, and then he maintains that as you put him on a more long immunomodulation therapy.
Right. Thank you, Dr. Surya. And that was a great collection of cases. And this will definitely be a great learning tool for everybody who watches this later as well. Moving forward, we actually don't have Dr. Joyita with us today to discuss eyelid retraction. However, since we've already discussed it earlier with respect to the triamcinolone injections, botulinum toxin surgery for the LPS, and maybe just a small point that lower lid retraction, you may need to use spacer grafts. Apart from that, we can just move on to Dr. Sumita Muthu's talk, and that'll be about strabismus. So I'm sure she was looking at the medial rectus that Dr. Surya pointed out in his endoscopic surgery. So she'll have some things to tell us about how to manage strabismus and maybe even how to prevent damaging the muscles. So over to you, Dr. Sumit. I think you're muted.
Yeah.
Yes.
Were you able to see my slides earlier?
Yeah, the slides are visible.
Oh, okay.
Just
okay. Yeah, thank you, Rituja and the Yosi team for having me as a part of this very important topic, especially for the postgraduates and also for the clinicians who manage thyroid eye disease. Again, once the orbit surgeons and or the oculoplasty specialists, once you manage and bring it to a stage where the disease becomes silent, that's where our role probably kicks in. And a little overview on what are the various stages
can you
of
just sorry to interrupt. Just put your slides in
Slideshare.
yeah,
sorry,
the presentation mode.
it is in presentation mode.
Okay, we are just seeing the
I think you can unshare your screen once and then go to the presentation mode and then reshare, then it automatically comes in.
One second. Let me just go in there.
Dr.
Okay.
Surya, I have one more
Sharing.
question for you. In which cases do you combine eyelid retraction surgeries with your orbital decompression, and when would you not do that specifically?
Thanks for the question. I think almost every time that I'm thinking about a surgery with a deep lateral wall and there is a retraction, I will almost always take care of the upper eyelid. Lower eyelid these days, I would almost every time take care during the surgery itself. But upper eyelids more often when you are doing a deep lateral along with that. Yeah.
Thank you.
Ritika, is it okay now?
it's still actually in that
Oh, I'm not sure why, because
Dr. Sumita, the icon at the bottom, which is like the fourth icon. Yeah, the right, left, on the left to the cursor.
sorry.
Towards the right.
This one?
Yes, click on that, please.
Okay.
It works. No, it's still not working. So, Dr. Sumita, just disconnect the sharing for once and then
I
go
did that.
slideshow in your mode And then when you share the screen, then choose the screen to the slide show
No,
already.
I did. I'm doing it to the slideshow. I don't know why it's not showing up. So what I'll do is I'll share it again.
Before you share, just put it in the slide.
Slideshow. Huh?
Yeah,
Yeah.
and
Okay,
then you
probably
can share.
before. Okay, I'll try that again. That's not working either.
Do you want to send it to us so that we can share from our side?
Won't that take too much
You can
time?
see your screen now.
You can see the screen, right?
Yeah.
And okay.
So it shared the screen where you have the Zoom on.
So see, so now
Yeah.
you can see the
Yeah.
screen, and I'm starting the slideshow. Every time I'm doing that, I don't know why it's not now.
Now it's
Yeah,
working.
now
Perfect.
it's
Okay, good. Okay. Yeah, I did the same thing every time. I guess third time is a charm.
yes.
All right. So, yeah, so we'll just be going through the stages of strabismus and thyroid eye disease, a little on how to evaluate strabismus and how do we manage strabismus in various stages and what are the unique challenges that we come across. So, see, when it comes to strabismus, it's very important that you know what stage we see the patient in. So, in the first stage, of course, as you guys already outlined, mostly it's management, it's conservative management, it's the management with steroids and addressing the thyroid status and surgery, of course, depending on the severity of the disease. Again, when it comes to the stage of fibrosis, is when strabismus needs to be really addressed. That's when the strabismus becomes stable. That's when we see a constant deviation, and there the role of a strabismologist comes. We either treat conservatively or go in for a surgical management. So again, conservative management is something that we do in the waiting period as well. While you're managing the thyroid eye disease, while you're making an active disease inactive, during this stage also conservative management of the strabismus can be done. And later, when it goes into the fibrotic stage, again, conservative treatment is preferred when the deviation is very small. This is done either with the help of prismatic glasses or with Botox injections. Local steroid injections, as was outlined for lid abnormalities, can also be tried for thyroid eye disease. Though I have little experience in this section, because I really don't use local steroid injection. I have not used local steroid injections in thyroid eye disease per se, but I do have experience of using local steroid injection in a non in an orbital inflammatory disease, where it has worked well in controlling the inflammation and bringing down the strabismus there and improving the movements as such. So perhaps there is a role in this as well. So coming to the surgical management, we only choose surgical management when we've had a Quiescent disease for more than 6 months, and when there is a large deviation, when the double vision is significant, when it is bothersome, and following decompression if the this deviation persists. So that is when we choose to do a surgical management. So we all know how to evaluate strabismus and thyroid eye disease, but as was outlined by the previous speaker, again, color vision, contrast sensitivity, and other aspects of vision, it's very important that we assess all of this at every visit. When it comes to strabismus per se, what we look at is the deviation in different gazes. The gaze measurements, again, becomes very important because as the patient moves into a fibrotic stage, what you see is the deviation in upgaze would increase more as compared to the primary position. So if you just keep looking at the deviation in the primary position, it may not change much through the various stages, but the deviation in upgaze definitely significantly changes, as the patient progresses through the various stages. So, diplopia and HES charting is again a very important tool in evaluating the severity of movement limitation. One, and second, it also tells us how much of the restriction component is there. in the initial period, when there is just a fatty infiltration of the tissues, or when there is inflammation, when the inflammation component is dominant, what we see is that there is more of a paralysis kind of picture, or just a weakness of muscles. But as they progress and move on to the fibrotic stage, we see that the restrictive component again takes over. Here again, force duction test becomes a very, very important tool. I'll be showing a short video on how to correctly perform a force duction test. Again, imaging is a very important tool here. So if you look at the force duction test, when you perform force duction test in a block, there is absolutely no problem. Under a peribulbar block, when you perform the test, there is absolutely no problem at all. But when you perform a force duction test under topical anesthesia, just look at what happens. So here you can see that the patient is trying to look straight ahead, and I'm trying to adduct the eye. But what's happening is, it seems like there is a significant restriction. But when I ask the patient to look in the direction of that muscle, then you see that the restriction is doesn't appear to be much. Okay, again, so the reason why I have why I'm playing this video is to outline that when you try to force a muscle into a particular position, which is against the direction of the muscle, or when the patient is trying to look in an opposite direction, you may falsely interpret the force duction test. Always compare with the apparently normal eye. That is one thing that you must do in order to prevent such false interpretation. The other thing that you can do is asking the patient to look in the direction, and then further go on to move the muscle in the same direction, to see if there is a restriction, or if there is if it is just a weakness of the muscle. And in order to grade the restriction, again, based on the amount of limitation, you can again grade the restriction. So I've already spoken about the evaluation of strabismus, and you've already gone through the various staging, so we are not going to go in detail with that. Now, coming to the surgical options, we all know that recession is the rule in thyroid eye disease. So, but there are various types of resection that you can do. Classically, what people used to do is a fixed recession, that is, try and do a fixed number for a particular amount of deviation, but that usually doesn't work in thyroid eye disease. Again, adjustable recession has been tried, where you keep the muscle on a complete on a complete hangback, and then do an adjustable recession of a IR, and on the post-operative day, on the first post-op day, or you can completely perform the surgery under topical anesthesia, and then adjust the position of the eye in real time. That is also possible. Especially this is suitable for thyroid eye disease, because you usually end up operating only the inferior rectus. So surgery under topical anesthesia can be a good choice. Semi adjustable recession of IR, again, I will show you a picture of that, what it looks like. What I generally perform is an intraoperative relaxed recession of the muscle, wherein we position the muscle based on the FDT on table, and I'll show you how that is done. Again, coming to how much recession must we do? Like I said, the standard tables which are there for deviations, for comitant deviations, do not work for thyroid eye disease. So the amount of recession is definitely not formula driven, but it is based on the FDT that you do on table. How much of a release is required to release the tightness is what you must assess. So there are certain unique challenges that we face during the surgery. For example, there is fibrosis and fatty infiltration of the muscle. So there is both a restrictive as well as a weakness component. And due to significant fibrosis, there is also fear of inducing inflammation when you perform a resection. So we end up performing recessions only. And there is a little debate on this. Some people say that when it is a completely inactive disease, and when the fibrotic component is not much, then you can perform small resections, is what has been told, and there are some papers on that. But personally, I have never performed any resections. Again, the accompanying lid abnormalities make it a challenge in handling the strabismus and thyroid eye disease. I'll show you in a few case examples that I have. Late overcorrections are again something that is seen, and we also see bilateral asymmetric involvement. So this is the adjustable recession of IR that I said. This is a complete hangback recession. That is from the insertion, you tend to uh, leave the muzzle on a hangback suture. This can be done, but again, there is a chance because of the tight muzzle. There is a chance that sometimes the muzzle creeps back, and you may end up in an undercorrection, or sometimes it may the muzzle may fall back, resulting in a late overcorrection. So this is very common with the adjustable recession. This is semi-adjustable recession, wherein you place the muzzle at one particular distance, and then you recess only the central part, or you adjust only the central one third or so. So this also gives a very good result in terms of an adjustable recession. But then the same disadvantages of an adjustable recession as before, but just that you do not see any under corrections in this case, because you can titrate the position of the eye on the first postoperative day. So coming to certain intraoperative considerations, it's very important to separate the lid retractors as far as possible. And when you mark the insertion, because of the tightness of the muzzle, what happens is, um, once you release the muzzle from the insertion, you see that as compared to a normal eye where the insertion only migrates up to 1 mm, in case of thyroid eye disease, the insertion can migrate almost 2 mm from the original insertion. So it is always important to mark the original the insertion before you release the muzzle after you tie the sutures. Then nasalization of inferior rectus is something that must be done whenever you plan large deviations. When you plan, say, a recession which is more than 5 or 6 millimeter, it's better to place the inferior rectus nasally. Then coming to, of course, the benefits of the surgery are obvious. There will be reduction in diplopia and improvement in the binocular single vision field. Again, most of these patients tend to have a chin up in order to avoid diplopia. So there will be elimination of the head posture as well. And so see, in any restrictive strabismus, it's very important to have realistic expectations. You cannot have perfectly aligned eyes in all 9 gazes. That is not possible. So what is desired is good alignment in the primary position and down gaze, which is very important for all of us, both in terms of us walking and reading and all of those. Because of all of these activities done in down gaze, it's very important that you achieve good alignment in down gaze, and again primary position. Up gaze may not be as important, and it's often difficult to achieve very good alignment in up gaze as well. So any correction which is less than 10 pd in the primary position and in down gaze is considered a successful outcome. So I'll just show you a couple of cases. The first patient, a patient who had diffuse goiter and Graves' disease, who was on neomercazole, and on examination she had a left hypotropia. This patient had a deviation of almost 35 prism diopters in the primary position, and if you see in the right gaze and left gaze, the deviation is different, obviously because inferior rectus causes more restriction in the lateral gazes as compared to the nasal position. So you can also see there is a corresponding limitation of the elevators over there. The FDT did show a restriction of elevation. So we performed a left adjustable IR recession. So here again, pay attention to the number. The number was quite high. So though I did a 6 mm recession, when I placed the muzzle, so this was not a relaxed. This was a relaxed recession that I performed. So in relaxed recession, what we do is first we place the muzzle at an approximate position on the sclera. Then we perform an FDT and see at what position the muzzle falls on the sclera. So we then fix the muzzle at that position on the sclera. So when we performed an FDT, we saw that the muscle was almost falling back to this position. And even after that, I still put the muscle on an adjustable position. And on the first post-op day, adjust the position of the muscle. So what I saw was that 3 months down the line, this patient ended up having a hypertropia, probably because of the amount of recession of the inferior rectus that the patient underwent, and again had a significant face turn because of that. I did try prisms, but the patient was definitely not happy with that. I don't have the pictures of the first visit, so I have included picture of the uh, pre-op visit, of the second surgery. So what you can see is, though the eye looks well aligned, she had a 10 prism diopter hypertropia. Okay, so you can see the position of the lid here looks almost okay, but we had to perform a small amount of superior rectus recession in order to align the eyes perfectly. So this relieved the patient of diplopia completely. But what was not apparent in the previous photograph is the lid retraction, which was present. But now that the eye position has been, now that the eyes have been aligned perfectly, you can see that the lid retraction becomes apparent. Again, when we perform large recessions, it's very important to go very posterior in terms of separation of the muzzle from the lid retractors. If not, we can end up having a retraction of the eyelid like this. So this can probably be a scope of discussion. I can take tips from our oculoplasty surgeons as to how to prevent such an occurrence probably later. So this is a second case, again, a patient who had hyperthyroidism and a left hypertrophy of almost 21 degree and -3 elevation. And here I had to perform a very, very large IR recession, again 13 with late nasal transposition. But look at the result. So every case is unique. Though I performed only 9 recession over there, we ended up having an overcorrection. But if you look at this particular patient who had a very severe restriction of elevation, you can see her 9 gaze photograph. The limitation is quite severe in abduction. You can see that the IR does not, the IR does not allow the superior rectus to act and elevate the eye at all. So this is the pre-op and the post-op picture. This was probably the immediate post-op. I think in the first or second week, what you can see is in the primary position, there's very good alignment, and in down gaze again, there is good alignment. Of course, there is some limitation of the inferior rectus, which is expected. And this is on last follow-up. You can see that the primary position, there is very good alignment. Again, in down gaze, whatever limitation we saw is almost not there. And this patient was definitely diplopia free in the primary as well as in the down gaze. So again, outlining the unique challenges that we face in thyroid eye disease in terms of correction of strabismus, as I previously mentioned, this is something that we must definitely remember. And every case is unique. As you saw in the first case, though a limited recession was performed, we ended up having an overcorrection, 3 months down the line, which again is common and documented in literature. And in the second case, of course, even several months down the line, she had good alignment, and the alignment was maintained without any overcorrection. So with that, I conclude my talk, and thank you, Rituja, once again. And I would like to take inputs from my oculoplasty colleagues as to how to prevent that kind of a little retraction. Though we think we have separated the retractors, what distance do you suggest we separate the rectus muscle from the surrounding tissues? Up to what distance must we go in order to ensure such a complication does not occur?
Okay, so first of all, great talk, especially for us as oculoplastic surgeons and oculoplastic fellows who will be watching. A lot of things which we may not have even thought about have come up in this talk. For example, with respect to the fact that resections are not commonly performed, and about the migration of the insertion. These are things which we probably would have never thought about. So thank you for that. And with respect to inferior rectus surgery later on causing lower lid retraction, I have seen a couple of cases. I've tried to treat it um, conservatively with 5 FUN fillers, and then I had to go on and do hard palate graft. But before we answer that or we get into that, what type of approach did you take? Was it a limbus based or a phonics based approach?
Usually, I perform phonics-based surgeries, and that's how I did for this case as well. Unless we find that there is significant contracture, and say the conjunctiva also is very much contracted and tight. In those cases, yes, a limbal approach may be preferred, because you may not have that much liberty in operating the phonics. You may not have that much space. Otherwise, phonics approach should be good.
Right. So I would say, since you're basically just handling the muscle, and you're not fiddling too much with the lower lid retractors, what could happen is that as you, since the retractors and the inferior rectus are connected to some extent, when you do recess or when you lower it down, since the retractors do go down simultaneously, we could maybe come up with an approach where the eyelid surgeon also gets involved, and sort of gets puts the retractors to one side, and then maybe
Oh,
reattaches them. uh,
okay.
in initial post-op period, 5 FU injections also could help to a great extent, or even
Okay.
steroid injections.
Okay.
Dr. Ayushi, what do you think?
Yeah, actually, I was also thinking that if you are suspecting something like that, maybe we can do a simultaneous lower lid retractor release if not done already, and we are expecting that there's a lot of fibrosis. But I don't think we can predict in
Mm.
which cases will you have that lid retraction so as to do lid retractor release. But definitely, with the amount of lid retraction that there is when the patient comes to you, maybe we can then predict that this patient may have a residual or even more lower lid retraction, and then at that time we can do a lower lid retractor release, the oculoplastic surgeon.
Okay, so your suggestion is that I call in an oculoplasty surgeon when I expect. No, no, no. I'm really asking.
Yeah.
When I expect that I have to perform very large recession, so get the retractors separated by an oculoplasty surgeon and then proceed with the recession. Would that be?
Maybe, and you can maybe analyze the cases, that the amount of cases where you got the lower eyelid retraction and how it was pre-operatively when you were about to operate that patient. Maybe when we have that data, we can uh, look at
Okay.
it and analyze it. If it's happening more in cases who already had a pre-operative lower eyelid retraction, or is it maybe it's something related to the patient and the surgeon factor.
Yeah.
Okay.
See, also, it can happen even when it's not thyroid related. That it's just
Yes.
any
Any inferior rectus recession. Yes.
rectus procedure. So um, maybe have somebody look into that, because I don't even remember how it looks. Other than the muscle being brought forward or recessed, I don't really remember how the uh, retractors sort of come into play with the muscle. So if we can just have somebody look into that at the time of surgery, to see if there's
Hmm.
anything we can do. But it could be inevitable also, because just mechanically the movement of the or the position of the muscle being changed. So
Hmm.
and
Yeah, sorry.
what do you yeah, what do you feel that we as oculoplastic surgeons during a decompression, other than tagging the muscles, how do you think we can sort of take care of it? Although we always have that after decompression, that the strabismus can be taken care of, but anything else that we could do?
So I think you already know that any amount of inflammation induced again induces some amount of fibrosis of the muscle. So as much as possible, try to keep the tissue around the muscle as much as possible intact, and just tag the muscle in the most atraumatic way. I think that itself will ensure that the deviation does not change post the decompression surgery. But however, the picture can change drastically in thyroid eye disease. We see that just in a month, when they go into the stage of fibrosis, there'll be a huge deviation which was probably not there earlier. So that kind of picture is also seen. And again, as the inflammation resolves, we have also seen large deviation almost completely disappearing and ending up requiring only prism correction. So this kind of scenario is also something that we commonly come across.
Right.
I had one last question, maybe that when we send a patient to you in the active phase, like 5 to 6 months, and the patient has diplopia. So between the prism glasses and botulinum toxin injections, which one do you prefer, and what is like how do you decide on that? Prism versus botulinum toxin for active.
So see, botulinum toxin is something I cannot titrate. I cannot titrate the effect of the botulinum toxin and the effect it has on the deviation much. But the prismatic correction is something that you can definitely titrate. Just excuse me 1 second. Huh? Sorry.
Dr. Rolika,
So,
meanwhile,
Rolika,
any other
yeah.
questions you want to accumulate or ask?
Sorry?
Any other question? Does it remain?
I actually wanted to ask Rolika about
Okay, okay.
how is the situation there in the US? Like, what do they do for strabismus in the active phase? Like, what is the preferred
Yeah.
approach?
In the active phase, strabismus surgery is ideally not performed, even in US platform. And once we reach the quiescent stage, that is when they go for it. In US, obviously, Stepeza is available, which shows excellent results. So we have three scenarios where we give Tepeza, everything works well, quiescent stage, go for strabismus surgery. Second scenario, they start with decompression because Tepeza cannot be given contraindicated, then quiescent phase, and then go ahead with strabismus surgeries. Or there are cases where we do Tepeza and decompression, and because there is still an aesthetic component left, and after that we have seen that strabismus is no more required. So even that is a part which can be looked at. So Tepeza with decompression, we don't need to do strabismus anymore.
Yeah, I think, as you rightly said, the picture almost changes every time, either a conservative management or a surgical management is done. The deviation changes significantly. So it's always important to wait. And so often we end up waiting at least for about 3 to 6 months once the definitive management is done by the orbital surgeon.
Right. Agree with that. And I think with that, we've had a fairly good discussion, well rounded, in fact, thanks to the start that we had with Dr. Sumer and Dr. Tarjini discussing almost each and every point um, about management. And then, of course, something niche that we got to see with Dr. Surya's talk, and the strabismus surgeon also educating us on how to manage squint. So uh, we had a good session, and we hope to have even more sessions like this, hopefully in future. And with that, we'd like to invite you all to the YOSICON, which is this time an international conference, participation from several countries, several international delegates attending, and it's happening in Delhi in September. So encouraging everybody to join YOSI, come to YOSICon, present, and get exposed. So anything you'd like to add, Ayushi?
Nothing, you've covered everything. I just want to thank Manjula ji for the streamless live streaming of seamless live streaming of this session, and all the panelists and speakers for being there today. And thanks to you and Rolika for the great discussion, and all the audience and participants for watching this and who will watch later, as you already mentioned. Thank you so much. We can have a Q selfie now.
Everyone,
We have a guest joining the selfie as
yeah,
well.
that one
Sounds
can
good.
also be assigned.
Rolika, can you take
Yeah,
the
sure.
picture?
Do that.
I would request the audience as well to switch on their videos. So, Dr. Vaishali, Dr. Santosh,
Just a second.
Dr. Silam.
Okay, perfect.
Thank you.
Thank
Right.
you.
Thank you, everyone. Have a good night.
Thank you, everyone. Thank you.
Thank you. Thank you. Good night.